So here I am at the uni. Of course, today is the day of my OSCE Resit. I am actually I feel like I'm going to throw up. I really, really do. I was up at 3 o'clock this morning. That's how nervous I've been. I mean, I know more this time. I remember more this time than what I did my first time. But the nerves are still there, especially considering I know I froze the last time and I messed up. And I just went blank. Kind of hoping that doesn't happen this time round. Do you know that way? I wish I could just fast forward time and it'd be about 10:30 or something, because that means it would already be done and I'd pretty much be halfway home. As you can see, still kind of got the shakes, and that's with 5 milligrams of diazepam. So no doubt once this is done, I will literally go home and sleep the day away. What people don't realise is sometimes the mental side of things is a lot harder than the physical. It's like being physically ill, it's not that great, but being mentally ill, it's tiring, because at least if you're physically ill, you know, you can maybe take pain meds or whatever and it will help you sleep. Even in sleep, your anxiety still plays on and on and on. You're not getting a break from it. It is just constant, and it just leaves you constantly knackered. It's like an everyday uphill battle. It's not nice at all. But I'm here, I'm doing it, I'm pushing through. I just need to keep my cool while I'm in there and just forget everything round about me and do what I've got to do. I don't like, it takes me a wee while to kind of think in something and remember it, but when you've got a camera recording you and a lecturer staring at you, it puts you off. You kind of feel as though you need to rush these things. It kind of makes you feel as though, oh crap, I'm standing here taking too long to answer. And on top of that, you've only got 20 minutes. So, I think I've got it. So let's try this here and now. I'm going to start with my introduction, which would be your first overall look at the patient. So, patient conscious or unconscious, well, not either conscious or unconscious, but preferably is the patient responsive or unresponsive. Then introducing who you are, your role, checking the patient's ID wristband with the details that you've got. If the patient's conscious, explaining your AE assessment and why you're doing it. If your patient's not conscious, I would maybe still explain it. And well, if you're not so responsive, should I say, I'd maybe still explain it, because it could be that they could still hear. If they're conscious as well, I would obviously ask consent to continue. If not, I would continue because it's in the patient's best interest for me to do so. So that's the introduction out of the way. I know I've not missed anything in that. airway, so for the airway, you're going to look for signs of cyanosis, which is basically blue colouring of the skin due to lack of oxygen. You're going to look for signs that the patient might have something in their throat, might have a blocked throat, so looking for like grabbing at the throat or facial expressions, you know, if they're unresponsive, you know, like head movement and things like that, as if they're trying to dislodge something. Also, if the patient's unable to speak, then that's obviously a massive giveaway that there's something wrong with the throat and the airway and that. So the other things I would kind of look for, listening wise, you'd listen for any sort of stridor, snoring, or gurgling noises. Gurgling tends to mean that there's maybe blood, vomit or mucus or something at the back of the throat. After that, I would look in patient's mouth, shine my torch in. Be looking for things like vomit, mucus or blood, or any sort of foreign object stuck there. Intervention wise, probably do head tilt, jaw thrust and suction if there's any mucus or anything there. If I need to do the head tilt and jaw thrust, I would ask obviously for help for that. And then I would let the examiner know whether the airway is patent or not. So I don't think I've missed anything there on airway. Breathing, going to be looking for like a respiratory pattern. So that's like the depth and, you know, how fast that their chest is going in and out. Chest expansion I'd be looking at, making sure both sides of the chest are even when they're breathing. I'd be looking for some sweating, because that would let me know they're in respiratory distress. I'm going to listen for any crackles, any wheezing, and overall sort of reduced noises coming from my patient. I'd look to see if they're using any accessory muscle usage, which would be like the raising of the shoulders, breathing in, the skin sucked into the ribs, and excessive abdominal movement. I would look at what their respiratory rate is, so checking the in and out breathing for 60 seconds, a minute. I would put the SpO2 meter on their finger to get their oxygen level, and I would also check the chest symmetry, which is both hands on the chest wall. When the patient breathes, the thumbs should come apart and then back together again, and that way you know they're breathing on equal sides. Intervention wise, I would give oxygen, obviously. If their oxygen level's low, I would sit the patient upright, because that's a better chance of getting oxygen in. And I would escalate any problems that maybe aren't controlled that great. Don't think I've missed anything there. Circulation, so I'd be looking for the likes of skin colour being pallor, which is sort of pale greyish of the lips and the eyelids. I'd be looking for any bleeding. I'd be looking for any sort of oedema signs. I would check their hydration, pinching the skin normally on the hand. I'd check the capillary refill time, which is pressing the nail, so when it goes white and you release it, it should go back to red, is normal. Capillary refill time, I would check their blood pressure. I would check their pulse using the radial artery. Yeah, using the radial artery. I'd check the skin temperature using the back of my hand on their sort of arms, their hands, their legs, you know, in general. Interventions, I would control any bleeding that I see, get an IV line in, cannula, and get fluids going. Don't think I've missed anything. C. D for disability, I would assess the patient's conscious level using ACIV-POO, which is alert, confused, voice, pain, and unresponsive. At that point, I would also check the blood glucose level, which is basically just pricking the finger, giving the finger a wipe, prick the finger, put the strip in the machine, and get a bit of blood on the strip, and that will tell me what the patient's blood sugars are. If it's below 4.9, then it's hypoglycemia. If it's above, I want to say 5, then it's a hypoglycemia. So I would, for interventions, I would treat either the hypo or the hyper, and escalate anything that isn't really improving. So that's D. So E, exposure and everything else, I would check the tympanic, I cannot pronounce that word, temperature, which is basically using the ear probe in the ear to check the body temperature. Visual assessment, I would be looking for any previous surgical wounds, or just any wounds in general. I'd be looking for any rashes on the skin. I'd be looking for a little edema on the legs, so build up of fluid would make the legs swell. Physical assessment, I'd be feeling the sort of abdomen and stomach to see if there's any tenderness or any swelling. I would be looking for tenderness, swelling, I can't remember what one I had for the last one, crap. Right, okay, so I've missed that. So after that, I would go on to checking if there's any pain. So I would look for signs of it, like grimacing on the face, making, you know, distressed facial expressions, and maybe moaning. If the patient can talk, I tell them to rate it 0 to 10. 10 being most painful and 0 being less painful. Then I would move on to checking the patient's, the events leading up to the situation. Then I would check the patient's background, the patient's allergy information, the patient's medication, see what relevant documents they've got, and put them on any relevant documents like observation charts, fluid charts, and things like that. Then I've gone to pretty much the end of the exam. I would name my two main priorities. I would state any other professionals that need to be involved in the situation, and I would make sure my documents are up to date. So that would be the exam complete, and I've only missed out one thing that I could not actually remember. So let's see my sheet. Let's see if I get right at that. So first impressions, responsive or unresponsive, introduce yourself, your role, confirm the patient ID, I can't remember if I said that, I did. Explain the AT, gain consent, look at the airway look, cyanosis, bluish skin colour, lack of oxygen, signs of choking such as throat grasping, unable to speak, listen, gurgling, snoring and stridor. Potential or actual obstructions would be blood, vomit, mucus. Is the airway patent? Yes or no. Intervention, head tilt, jaw thrust and suction. Breathing, be looking for sweating, rest pattern, chest expansion. Listening for wheeze, crackling and reduced sounds. Check SpO2, rest breaks, accessory muscle use, raising the shoulders, skin sucked into the ribs, excess abdominal movement. Intervention, oxygen sit up and escalate. Circulation, be looking for pallor, greyish or pale eyelids and lips. Be looking for bleeding or edema. Check for hydration, pinching the skin. CRT, capillary refill time, that's the pressing the nail. Temperature using the back of the hand. Blood pressure and the pulse reading of the radio artery. Intervention, control the bleeding, get IV access and fluids. Conscious level the ACAV-poo, alert, confused, voice, pain and unresponsive. Check the blood glucose. Control hypoglycemia or hyperglycemia. Escalate if needed. Exposure and everything else. Check the ear temperature. I think I said that, yeah. Typhami, or however you pronounce it. Visual, previous surgery, wounds, pressure sores and rashes. Physical, swelling, edema and tenderness. I missed the swelling or tenderness, I think I missed. I can't remember. Pain signs, grimacing, moaning, fever in a certain area. Pain score 0 to 10. Check the events leading up, the background, the medication, the allergy and relevant document, and repeat observations and escalate. And then obviously my last part, which is do all my documentation and name my main priority and things like that. So overall I've done not too bad there as well, and that was without my sheets. So hopefully I can go in there and do what I've just done here. So fingers crossed for me, guys. I really hope to come out of there with very good news, but we will see. Yeah, so I'm going to finish this here and continue studying a wee bit more.